Now, for our final topic, let's talk briefly about treatment of TB in children. My first word of advice, unless you work in a clinic that does this routinely, send the child to a TB clinic with pediatric expertise. If you can't find this kind of resource for your patient, talk to your local health department and be in regular contact with a pediatric TB consultant. Treatment of pediatric TB is very similar to treatment of adult TB. Under most circumstances, 4-drug empiric therapy is initiated using directly observed therapy, also known as DOT. DOT is the practice of having a non-family member observe the patient taking the medication. On average, patients who self-administer their TB medications complete therapy about 60% of the time. A good DOT program can increase the completion rate to the 90% range. DOT can take place at the patient's home, at work, in school, in the clinic, or even on the street corner. DOT workers have to be creative and work within the context of the patient's situation. For select families whose children are tolerating therapy well, sometimes video or FaceTime DOT can allow for a less expensive, more flexible, and less intrusive support and monitoring. For example, the family doesn't have to wait at home for an outreach worker. They can take a family trip without inconvenient DOT arrangements or missed doses. For some families with hard-to-dose children, the meds can be given at odd hours and the video files submitted electronically to the public health department. This table shows the 4 first-line TB drugs and the doses used for children. See the resources for easy-to-use weight-band dosing. Most patients should receive all 4 first-line drugs as empiric TB therapy. After the child's or their source case isolate is known to be susceptible to the first-line drugs, ethambutol can be stopped. Sometimes when a child is initiating TB therapy, we already know that their source case isolate is susceptible to the first-line drugs. In this case, we can begin with just isoniazid, rifampin, and pyrazinamide. In the past, some providers were reluctant to use ethambutol in young children. Adults occasionally have optic toxicity from ethambutol, particularly if they receive a high dose. Fortunately, children rarely, if ever, suffer from ethambutol optic toxicity. A note about dosing. Rifampin is dosed at 15 to 20 milligram per kilogram daily for most children with TB, but higher doses are used for infants, toddlers, and even older kids with widespread or CNS TB. This dose is in the footnotes of the table, 20 to 30 milligram per kilogram per day. Occasionally, we use 3 times weekly dosing of the TB meds in the continuation phase, but daily dosing is preferred. See the resources for 3 times weekly dosing for the rare situation where that regimen works best for the family and health department. This slide shows the typical course of treatment. All children should be treated in collaboration with the local health jurisdiction by directly observed therapy, also known as DOT. In-person DOT is preferred in the beginning, but virtual monitoring actually works better for some families after a good pattern is established. The health department usually performs DOT on weekdays, and the families provide self-administered therapy on the weekends and holidays. The 4 first-line drugs are started empirically. Ethambutol, also known as EMB, is stopped when the child or source case isolate is known to be susceptible. If the TB isolate is resistant to any of the first-line medications, urgently consult a pediatric TB consultant. INH and PZA monoresistance are easy to manage, but rifampin resistance almost always indicates multi-drug resistant TB, which requires a very detailed treatment plan. After 2 months of observed therapy, most TB providers repeat a chest radiograph and assess the patient clinically. The regimen can be changed to INH and RIF if the child has received 56 daily doses of PZA, usually that's 40 observed weekday doses. The patient is doing well, that is gaining weight and not worsening clinically or radiographically, and is taking and retaining each DOT dose and appears to be absorbing the drugs. And finally, that there is no concern for drug resistance. The chest radiograph is often not better, and sometimes it's worse than it was before starting therapy. This is usually due to the so-called paradoxical reaction with enlargement of lymph nodes, sometimes causing atelectasis or air trapping. It's important to consider whether the child is receiving the right meds, getting the right doses, adherent to therapy, appears to be absorbing the doses, and is clinically improving. Usually, even if the radiograph is not better, the child is doing well, we can change to INH and rifampin for the continuation phase. Experts disagree on management of children who do not have any susceptibility results for themselves or a source case. See the resource material for various options and considerations. If the child or their family come from a part of the world with a lot of drug resistance, there's a risk of treatment failure if you don't use the correct regimen. The duration of the continuation phase has traditionally been 4 or more months of therapy. However, children are known to have relative paucibacillary tuberculosis, meaning they have many fewer TB bacteria in their lungs than many adults do. TB clinicians have often wondered if children with modest disease need the same duration of therapy as adult TB patients. Some studies of presumed paucibacillary TB in adults have shown success with 4 months of total TB treatment, and it makes sense that kids might also be cured with a 4-month TB regimen. In a recent clinical trial published in 2022, 1,200 children in India and Africa were studied to compare 4 versus 6 months of non-severe TB disease treatment. On the next slide, I'll share the definition for non-severe TB used in this trial. Initial therapy was standard isoniazid, rifampin, pyrazinamide, and ethambutol for 2 months, with some dose modifications allowed for local practice. After the initial 2 months, the regimen was followed by 2 more months of isoniazid and rifampin for a total of 4 months in the treatment group and the standard 4 more months in the control arm. Only 3% of children in each group had an unfavorable outcome, showing that 4 months of treatment is non-inferior to 6 months for non-severe pediatric TB. The reference for this trial can be found by searching the internet for the SHINE trial for treatment of non-severe TB in children. Based on the data from this well-performed trial, pediatric TB experts in the U.S. now often use a total of 4 months of TB therapy for children with non-severe disease, good response to therapy, and no evidence of drug resistance. Non-severe TB disease for this study was defined as peripheral lymph node TB or intrathoracic TB. The children could not have disseminated, miliary, CNS TB, or extrapulmonary TB except lymph node TB. Children with intrathoracic TB, including pulmonary TB, had to have smear-negative sputum or gastric aspirates, and they had to have presumed drug-susceptible disease. Their chest findings had to show disease in a single lobe of the lung without cavities and without a miliary pattern. If they had pleural disease, they could not have complex pleural effusion. Intrathoracic lymph node TB is very common in pediatric TB, but for this trial, there could not be significant airway obstruction or bilateral airway narrowing. Several features make pediatric TB therapy a little more challenging than treatment of adults. First, microbiologic confirmation is less common, and therefore monitoring the success of therapy by serial sputum culture and smear is nearly impossible. Second, monitoring for toxicity is a little more difficult, especially in the youngest children. Fortunately, children seem to tolerate the regimens better with fewer side effects than do adults. Finally, in the U.S., most of the first-line TB drugs are only available in tablets or capsules. INH is available as a liquid suspension, but causes diarrhea and stomach upset in many kids. Rifampin suspension can be compounded by some pharmacies and worth trying for some families. Generally, capsules need to be opened, tablets crushed or fragmented, and the drug hidden into soft foods or tiny amounts of liquid. More about this later. Every family and every public health team finds the tricks that work for that child, but it often is a process of trial and error with incentives and creativity. Here are a few dosing tips. Families and DOT workers should anticipate a trial and error period for 1 to 2 weeks and should not alienate the child while figuring out a good system. Every child has individual preferences. Some like maple syrup, some like chili, some like Nutella, some like spinach baby food. Almost everyone likes chocolate whipped cream. Try to make layers of vehicle, crushed or fragmented pill, topped with more vehicle on a spoon. If you can teach the child to take the contents of the spoon without chewing, the child won't taste the drugs. Be prepared to try a new trick or offer a new incentive, but never give the child the idea that the dose is optional or that the child is in charge of the situation. Again, see the resources for more ideas. Certain circumstances require prolonged therapy. If the disease is extensive or slow to respond to therapy, if the patient has TB meningitis, or in some cases osteomyelitis, typically treated for 12 months, If the TB isolate is drug resistant, this includes treatment of Mycobacterium bovis disease, which is inherently resistant to pyrazinamide and seems to be sluggishly responsive to therapy anyway. And finally, patients who have been poorly adherent will require a prolonged course of therapy. So the trickiest part is getting kids to take the medication. That requires patience and creativity and regular reassessment. In conclusion, I'd like to reiterate these 4 main points. First, pediatric TB is relatively uncommon in the United States and is therefore sometimes missed. Second, screen healthy children with risk factor questionnaires and reserve TB testing for those children at risk of exposure or disease. Third, evaluate those children exposed to active cases of TB promptly and thoroughly because they are at the highest risk of infection and disease. And finally, evaluation of children with symptoms concerning for TB or with abnormal radiographs is tricky because not all children with TB will have a positive TB test, and not all children with positive TB tests and radiographic abnormalities will have TB. It's a bit of an art to sort out these groups and to avoid progression of disease and unnecessary drug exposure. The good news is you're not in it alone, and we are here to help. It's been my pleasure to share this information with you today. Don't forget to peruse the course resource materials for lots of handy forms, tables, references, and algorithms. Share them with your friends and colleagues, and be sure to call a pediatric TB expert when you can't figure it out easily for yourself. Thank you for your care of the children.